I'm Ryan Luellwitz. I'm one of the OBGYNs, or general OBGYNs here in the department. I've been on a hiatus for the last year doing a critical care fellowship here at the main hospital. That ends actually today. So, following fellowship, I'll be back in the department doing mostly inpatient OBGYN, and then I'll be also working for the internal medicine department at the ICU at Merritt as well. So I'll be in the hospital a lot more. Yeah, so topic we're gonna cover today, shock management for the OBGYN. Got a couple of goals if the keys wanna work. Let's see here. There we go. All right, so we're gonna identify different types of shock and causes behind those shock states. And then we're gonna talk a little bit about the management of the initial resuscitation. And I wanna preface this by saying this is not an exhaustive review of how to take care of shock, right? You know, you're probably not gonna have to manage it beyond the initial phase. And then if someone's still having trouble, you're gonna call for help. Okay, we'll talk a little bit about that, what that looks like. This also isn't really gonna be a exhaustive review of how to manage somebody's hemorrhage or how to manage their sepsis. We're going to talk again about the initial resuscitation. But you're all in residency or have done residency to learn how to manage a hemorrhage. And I don't think for this talk we needed to go over that. Okay. So why is this important, right? Well, according to the CDC, the leading causes of maternal mortality in the United States are hemorrhage, that's number one, sepsis or infection is number two. And then these aren't all of the causes, and they're, I sort of cherry pick the ones that actually have to do with shock states. But if you look at these, thrombotic, pulmonary embolism, or other embolisms, cardiovascular conditions, cardiomyopathy, or amniotic fluid embolisms, all of these are usually preceded by some sort of shock state. Okay, and so there's, when we have a maternal mortality, usually it's going to be preceded by shock. And what's really important to know is that 84% of these deaths are actually considered preventable. So knowing what to do at the initial management is going to be key to help your patient survive. Postpartum hemorrhages complicate about 3% of pregnancies in this country. Granted, this seems low to me because it feels like we're always having hemorrhages here, but we also have we were very self-selected for patients for hemorrhages here at Merritt. When I was working down in Janesville, I rarely ever had a hemorrhage. Like, I was trying to think about it last night. I'm like, I don't remember actually ever having a really bad hemorrhage down there. Because again, these were low-risk patients, right? They already sent all of their high-risk patients up to St. Mary's here, or UW. And then sepsis affects 4 in 10,000 births. Again, we're self-selecting, at Merritt to get more of these cases, but even in a rural setting, these things can happen. Worldwide, this is a problem too. Hemorrhage is the leading cause of death worldwide from maternal mortality, 27%. There was a study where they looked at sepsis cases throughout the world, and they showed that infection affected 70 out of 1,000 live births, and 34% of those had to be stepped up to a higher level of care or transferred to an ICU. The gynecologists, you aren't off the hook either. No, it doesn't seem like we have any gyn-oncs here, but they're the main culprits. So 7% of ovarian cancer cases end up in the ICU. 85% or 84% of those were due to hemodynamic monitoring or blood pressure support, which kind of sounds like shock. An older study said that 6% of gyn-onc patients ended up in the ICU. 58% due to volume resuscitation also sounds like shock. And then there was this data reporting system for the Da Vinci robot, and they looked at deaths associated with the Da Vinci robot. And again, this is an incredibly rare event. I don't want to make it sound like, you're going to go do your benign hysterectomy and end up, with a death, which is pretty rare. But when it did happen, if you look at most of these would probably be preceded by shock states. So that's why I think it's important that we know what to do to identify shock and how to manage it initially. So what is it, right? Is it hypotension, low blood pressure? I think a lot of people, we think about that. Could it be hypoxia or hypoxemia, right? So low oxygen in the tissues or in the bloodstream. Is it hypoperfusion or cardiac dysfunction? Well, some really smart people got together and they said, we should make a definition of this. And they did, and I really like this definition. I'm just gonna read it word for word. But anyways, shock is defined as a life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. Okay, so something going wrong with the way that we get blood around and then not having enough oxygen to be utilized by those cells, or inappropriate usage of that oxygen. Okay. Now, when I'm getting called, when I'm in the ICU, I'm not thinking about this definition, right? I'm not like, oh man, like, like this is circulatory failure with, inadequate oxygen utilization. I think about it actually in a different framework, and that's the framework I'm going to use for this talk today. Okay. I'm thinking about it. Is it a problem with the pump or a problem with the heart, right? And the blood's not able to get around. Is it a problem with the pipes, right? And there's not enough resistance, and so the blood's just not getting where it needs to go. It's not delivering that oxygen to the cells. Or is it a problem with the volume or the blood itself? We don't have enough. We don't have enough red blood cells to carry that oxygen to the cells, okay? And that's the framework I'm going to use today, talking about shock and how we identify these different causes, okay? So I know nobody really likes equations, but I have to know these for my boards, so we're going to talk about it today. But anyways, there's a couple of equations we're going to use. First one is going to be blood pressure, which is equal to our cardiac output and our systemic vascular resistance, right? So how much blood the heart's pumping out, and then the resistance in those blood vessels. And when we look at the equation for cardiac output, it's our heart rate times our stroke volume. So how much volume we're getting through by how fast the heart can pump it out. Okay. So when you give somebody fluids, which is something that we commonly do, the idea is that you're going to increase their cardiac output. Okay. Our systemic vascular resistance is our mean arterial pressure minus our CVP divided by cardiac output. So when you give somebody vasopressors, you're trying to increase their systemic vascular resistance. You're trying to increase the resistance in those vessels to help get the blood around, okay? So either you're trying to increase the amount of blood the heart is pumping or increase the resistance. That's really kind of what you're doing in that scenario. The other equation we have to look at, and this one's much more frustrating, is your DO2, or your arterial oxygen delivery, right? Which is our cardiac output times our arterial oxygen content. And really the main thing I want you to think about in this equation is our hemoglobin, right? Hemoglobin is important in this one because if you don't have enough red blood cells to carry around oxygen, that's where that whole inadequate usage or utilization of the oxygen comes in, okay? The whole point of this is that when we're trying to treat somebody for shock, we're trying to optimize the delivery and utilization of oxygen. Okay, that's really the name of the game. Without that, our cells aren't going to work properly. Okay, like any good presentation, we should probably follow a case, right? So we're going to follow Becky here. Sorry if any of you are all named Becky. This isn't about any specific person. My wife's nickname is Becky. Her real name's Emily. It's a long story. But anyways, so I figured I would pick on my wife a little bit here and then come up with this character. Also, AI is great for making graphics, by the way. Anyways, Becky is a 24-year-old G1, P0 at 39 weeks, got a little bit of GDM with some macrosomia, no past medical history, no surgical history, no allergies. And they're coming in to the hospital to have a baby. So the induction goes a little bit longer. Ultimately, there's a spontaneous vaginal delivery after 2 hours. Get some Pitocin after delivery. Her bleeding increases quickly after that. After delivery of the placenta, there's concerning for some retained tissue. Go to the operating room, undergoes dilation and curettage, retained tissue, get some TXA, some methogen, start on a little bit of norepinephrine. Total blood loss is 3.2 liters. She gets 2 units of PRBCs, 1 unit of lactated ringers, And she's transferred to the PACU after procedure, still requiring some norepinephrine to maintain a mean arterial pressure of 65. So what kind of shock do we think this patient's in? Probably hemorrhagic shock, right? Lost a lot of blood. 3.2 liters, I mean, that's like half the blood volume, right? So maybe a little under. All right, again, I told you we're gonna talk about these equations, right? So what's happening here, right? She lost a lot of volume. We don't have enough volume to maintain appropriate cardiac output. It really doesn't look like we replaced enough to keep that up, okay? Also, what's happening here, because remember we talked about shock is the definition of circulatory failure plus inadequate utilization of O2. We don't have enough red blood cells to carry that oxygen around, okay? And so looking at the framework, right? Pump, pipes, or volume, what's the problem here? Problem here is we don't have enough volume, right? And so that's what we need to do is we need to replace that volume. So in a hemorrhage, there's two main goals, right? There's two things that we want to do. One is stop the bleeding, okay? Because if you don't stop the bleeding, well, it's never going to get better, right? And then the other thing is we need to replace that volume. And it's not just volume, it's we need to replace that blood, okay? Our vascular resistance is already at its maximum. Those blood vessels, they're squeezing as tight as they can, trying to keep everything going here. But what we need is we need more blood, we need more volume, okay? And I'm going to argue that blood replacement is really, really important in these situations. And I think it's one of the things that we get into fights for whatever reason with our anesthesiologists about, like, should we give some more blood? Well, probably should. So how do we give somebody blood, right? Like, how do we resuscitate a patient? Well, the most important thing is vascular access, okay? And, when I was very early in my, medical training, I thought that like having giant like IVs in somebody's neck was going to be the best way to get them fluids, right? Or blood. That's just not the case. It actually has to do with the radius and the length of the vascular catheter, okay? And a short, fat vascular catheter is more efficient in replacing someone's blood products than a big central line, okay? And you can look at this chart here, right? And this website you can go to. This is a website by a semi-famous critical care doc who has these nice little one-pagers to talk about different critical care topics. But anyways, when you look at this chart here, you can see the flow rates of different vascular catheters. And a 16 gauge can do 205 mLs per minute, whereas a triple lumen, which is this one here, that's the most common one we put in the ICU, can only put in 105, okay? And then until you get to these really large perfusion catheters, you're not even gonna get close to what a large bore IV can. So the biggest thing when we're trying to replace somebody's volume is get more IV access and get the biggest, shortest IV you can, okay? And again, radius is gonna be the biggest part of this because if you look at this equation here, the radius is the fourth power. Okay, so that's going to play the biggest role. So the largest gauge that someone can place is going to be best. Okay. So what do the guidelines tell us about resuscitating somebody in hemorrhagic shock? So ACOG and FIGO have a couple of them. Okay. Like I mentioned, source control is our first line. And as I said, I'm not going to lecture you on how to stop a hemorrhage. That's what you're going to residency or you've been through residency to do. Okay. And most of you, I'm expecting you to all be experts when you get done with your training at this, okay? Because we do this all the time. But uterotonics, your first line, TXA, balloon tamponade, or a JADA, UAE, and then eventually, if there's too much bleeding, right? You got to do surgery. You got to take the uterus out, or you got to do a DNC, and we just had to do that last week, okay? So, fortunately, that happens. And then again, we need to replace that volume. In our young, healthy patient population, we're usually going to see the hemodynamic changes later, okay? And so for us, it's probably imperative that we start this resuscitation sooner so that we don't get behind, all right? Now, balanced crystalloid or lactated ringers is going to be your best solution. They did a big study where they looked at lactated ringers versus normal saline in critically ill patients, and lactated ringers was better. Okay, so that's going to be our first choice. I like to give 500 ml boluses, okay? And when I'm in the ICU, I always tell the residents, I can always give more, right? But it's harder for me to take it away. That takes a lot more work. Either I gotta give a lot of diuretics and then that's delayed, or I gotta put a needle somewhere and drain it out, okay? Which you can do, but it's ideal if you don't have to do that. So I like boluses of 500, and I can keep giving more. And then I can also follow to see if the patient's actually responding to that. Because again, if you just give too much crystalloid right away, you can end up with pulmonary edema, that can cause somebody to stop breathing, and that's no good. And then we want to give blood products, okay? And ACOG recommends that once we hit a 1,500 mLs of blood loss, we should start giving blood, okay? Or vital sign changes. I think that's important because I think a lot of times, you know, we're stuck on how much blood is actually being lost. And, you know, we're behind a curtain, we're not necessarily seeing the monitor, but that's something that, you know, we should be paying attention to if we can. And then if we start to see that tachycardia, that respiratory rate go up, you know, or they're getting hypotensive, then we need to start giving blood products sooner, okay? Because remember, our shock definition, circulatory failure with inadequate oxygen utilization. So we need that hemoglobin to help keep our patient out of the shock state or correct the shock state if they're already in it. So then what they usually recommend is 2 to 4 units of PRVCs. Okay, that's going to be your initial blood product resuscitation. And then if you get beyond that, then you need to go to a massive transfusion protocol. And a massive transfusion protocol, I think most of us are comfortable with that, is usually a 1-to-1 ratio of packed red blood cells, fresh frozen plasma, and platelets. Now, some of these will say like 661. And the reason for that is because platelets are delivered in a weird way, right? You get like a 6-pack of platelets. So really, you're actually still doing a 1-to-1 ratio, but the way we order them is in this like large volume package, okay? So, and then you do this until you have source control, or it's futile. For us, we almost never reach futility, but again, in the ICU, you do reach that. So how do we guide our resuscitation? Like, when do we know when to stop giving somebody blood products or stop giving somebody volume? So one, we want no active bleeding, and this is from these guidelines. So ACOG and, you know, the other OBGYN guidelines don't really have like a specific like cutoffs for these. So I'm borrowing a little things from the American College of Surgeons. This is the trauma data here. And this table, this is from a paper about amniotic fluid embolism. And I just thought it was a good sort of framework that we can use as OBGYNs. So one, we want no active bleeding, okay? American College of Surgeons, they want a hemoglobin greater than 10 in trauma patients. ACOG says 7 in their practice bulletin, which I think is somewhere in between there is reasonable. But what I want to stress here is that not everybody is good with a hemoglobin of 7. We don't need to be married to that number, okay? Just remember, getting back to that definition and our equations, right? We need adequate oxygen delivery, okay? And so not everyone's going to be great with a hemoglobin of 7. And there's, again, in our population, yeah, probably they will. But, you know, sometimes you look at a patient, you're like, maybe they just need some more blood. And sometimes that's a Gestalt thing, and you just have to give them more blood, okay? And then, you know, we want to make sure that their coags are normal. So again, we don't usually use PT all that much, but less than 18 seconds of PTT, less than 35. Platelets greater than 150. You know, you could argue platelets greater than 50,000. You know, someone who I'm worried is going to go back to surgery, I like it better than 100. But if they're not actively bleeding, I'm not anticipating, like I feel like I got really good source control, I think 50,000 is appropriate. 150 seems a little bit high. And that's, again, you can see on this table, the transfusion threshold is 50,000, okay? And then a fibrinogen, somewhere between greater than 100, and then some people recommend greater than 200, okay? So again, there's not like one set number that you have to have here. I think you kind of have to look at your patient and say, what's the spot that they need, okay? Now I want to talk about how much blood, like going back to our case, right? This person lost 3.2 liters and they received 2 units of PRBCs and a liter of crystalloid. So how much blood is that? How much blood did we actually replace? Well, 1 unit of PRBCs is equal to 300 mLs, which is the same oxygen carrying capacity as 450 milliliters, okay? So really, the patient in our case here, they got about 900 mLs of blood back, okay? And then they got some fluid, so they're still really not adequately resuscitated. Something else that's coming down the pipe that I think y'all will see more in the future is something called the TAG. Maybe you guys have heard of this before, or thromboelastography. And what this is these are point of care testing. They take some blood, they throw it through this analyzer, then it comes out with this arrowhead looking thing here, okay? And there's really two things you gotta remember about this arrowhead, okay? And what this is showing us is this is showing us this R time here, okay? From when they start to when the clot starts to form, okay? And if that's prolonged, like you have a really long R time, they need more product, so FFP or cryo, so that they can start the clotting process, okay? Because that means it's delayed, there's not enough product. And then the other number or the other value that you should pay attention to is this max amplitude here, okay? And what that is that's really showing the strength of the clot before you get to thrombolysis, okay? And if the clot's not very strong, they need more platelets, okay? Because platelets are the backbone of, building a clot, okay? And so those are the two main ones. If you want a quick and dirty way to do this, you got a low max amplitude, give them more platelets. If they have a short R time or a long R time, give them more FFP. Now, there are some data about this in postpartum hemorrhage, okay? It's shown that it's decreased use of blood products, decreased rates of blood loss, as well as hysterectomy, length of stay in ICU admissions. So I think you're gonna see this more and more as this becomes more popular. Not all hospitals have this technology, not everybody knows what to do with it. But again, I think in the next 10 years, this is gonna be guiding our resuscitation. They're using it a lot in the trauma world because it's easy and it's quick and you can get this data fast, okay? So let's get back to our patient. As we talked about, probably got under-resuscitated. Using our framework, there's a problem with the blood here. We didn't have enough blood to fix this patient's shock. So what did we do? Gave an extra unit of, extra liter of crystalloid, 2 units of PRBCs, 1 unit of FFP, and labs normalized, got off depressors. She goes to the postpartum unit. She does well over the next 48 hours. Well, the night resident got called to her room 2 days later. Hypotension, tachycardia, and malaise. Oh man, Becky's having a rough go. On exam, Becky's pale. She's diaphoretic. She just appears ill. You can see she does not look good, but she's thinking about a baby. All right. Vitals are not great. Her blood pressure is 84/40, which is a MAP of 55. She's tachycardic. Her respiratory rate's up. So this night resident, they're astute. They said, oh, I gotta figure out what's going on. So they ordered some labs, chest X-ray, and they came to this talk. So they ordered 500 mLs of crystalloid for this patient. You get the labs back. They're notable for a white blood cell count of 22. Platelets are low, a little bit at 94. And there's a lactate of 4.3. What do we think's happening here? I heard it talking about sepsis, right? Yeah, that's what this looks like. She's got risk factors, right? Just had a baby, pushed for a long time, had a procedure afterwards. So definitely in the right risk category for this. So what is sepsis, right? I like this. It's a life-threatening condition that arises when the body's response to an infection injures its own tissue and organs, right? And when you think about sepsis can affect any organ system. It can affect your kidneys, it can affect your brain, affect your heart, lungs. So not everyone has to if you have somebody that's maybe afebrile, but they're confused, well, that can be a sign of sepsis, okay? So you have to keep that in your framework that you're always thinking about, man, this could be anything, right? It's like it's like syphilis, right? Syphilis is like the great, presents any way. Well, so can sepsis, okay? What's septic shock? Well, septic shock is sepsis with persistent hypotension requiring vasopressors to maintain a MAP greater than 65, serum lactate level greater than 2, despite adequate volume resuscitation. So getting back to our shock definition that we talked about at the very beginning, right? So we're having circulatory collapse, right? Or circulatory failure, whatever you want to say, hypotension, okay? And we're having inadequate utilization of oxygen or cells. That's where our lactate's coming from, okay? And using our little framework of pipe or pumps, pipes, and volume, what's the problem here? Well, here it's the pipes, okay? We aren't able to maintain a systemic vascular resistance high enough to keep the blood moving around, okay? And so, gotta get back to our equations here, all right? So blood pressure equals cardiac output times SVR. All right, you've got this cytokine storm, right, that happens with the infection, which decreases your systemic vascular resistance, okay? We call this a distributive or vasodilatory shock. So as the SVR decreases, guess what's gonna go up? Your cardiac output's gonna increase because you're trying to maintain that so the patients get tachycardic, okay? They're working harder to get that blood around. And then we look at our DO2, okay? We're having underperfusion of our cells, okay? Which leads to anaerobic metabolism by those cells, which then leads to lactate production, okay? And that's what's happening here. So it meets our definition, okay? So how do we treat these? It's gonna be source control. Source control is a little bit different in sepsis. Source control is either gonna be giving antibiotics, it's gonna be drainage, so if you got an abscess, you gotta get all that stuff out of there. Or if you have an infected organ, sometimes you gotta take it out, right? You got bowel that's dying, you gotta get it out. You got uterus that, like we had a case, we had a lot of cases last week that were kind of odd. But anyways, we had an infected uterus that we had to remove, right? So it's, again, it's source control. And then we need to increase our cardiac output as best we can, okay? And so we're gonna give some fluids, okay? We'll talk about that a little bit more. But many patients are gonna need vasopressors because you can give fluids till somebody's blue in the face, but if you don't increase their systemic vascular resistance in septic shock, they're not gonna get better, okay? And so eventually, you either gotta let those antibiotics do their thing, do your IND, do your surgery, or you gotta give them vasopressors, okay? So what are the guidelines now? So I think most of us have heard of the surviving sepsis guidelines. It's something that comes out every few years. A bunch of really smart people get together and talk about how should we treat sepsis, okay? The mainstay of this is fluid resuscitation. That's the initial thing. And they used to have this thing about 30 mLs per kg. That was like the big thing, 30 mLs per kg, 30 mLs per kg. Well, it's starting to turn out that maybe that's not the best idea, okay? And that's really not what's recommended anymore. I put it in here, but because if you need a framework, it's kind of what you can use. But they're showing that not everybody needs this much, and maybe some people need more. And so what we really want to do is we want to have a dynamic measurement, okay, of like, are they responding to fluids, okay? And there's a bunch of different ways you can do this. And if you have invasive hemodynamic monitoring, like a central line, or you got an ART line, you can hook it up, and there's these computer algorithms that can show you pulse pressure variation, things like that. But there's also a really easy test that has the highest recommendation. That's cap refill, okay? So going to your patient's side, looking at how their capillaries are filling back up is actually what is recommended to see if your volume resuscitation is actually working. And that's really something easy that we can do at the bedside. It doesn't cost us anything. You don't need a central line. You don't need an ART line. You can just do that while you're trying to resuscitate your patient, okay? And if the patient's responding, well, then maybe you give them a little bit more fluid. But if they're not, then maybe they need pressors, okay? The other goal of volume resuscitation, or really the goal, is to decrease that serum lactate, right? Because we want to increase that cardiac output, get more oxygen to those cells, okay? And that's really what we're looking for, is a decrease in our initial lactate to the next one that you draw, okay? You want to maintain a mean arterial pressure of 65. If you're going to start vasopressors, norepinephrine is going to be your first line, okay? You can order vasopressors, by the way. All of you can. I know, obviously, it's something that you don't do a lot, but if you need to, you can order it and then call for help, okay? At least get the vasopressors on their way, okay? And then call a rapid, people will show up and they'll help you titrate it and run it and all that sort of stuff. And I'm more than happy to go through y'all with this. All right, you also want to get some blood cultures, hopefully before you give antibiotics. Get that serum lactate we talked about. And we really want to give antibiotics within 1 hour of recognizing the infection, okay? And broad spectrum. And broad spectrum means you want to cover what you think is affecting the patient. If you have somebody who you think has a UTI, which is causing their septic shock, giving them vancomycin probably isn't going to be your best drug of choice, because gram-negative rods are going to be more common in a urinary tract infection. Now, I'm not saying you can't give them vanco, because many times we'll have broad spectrum patients with vanc and zosyn, right? That's our combo we love. So you can do that, but you need to make sure that you're covering the source, okay? Yeah, if it's a skin infection, well then vanco is going to make a lot more sense, right? And plus or minus MRSA coverage. MRSA coverage, you know, I think we really just broad spectrum everybody with vancomycin for this MRSA coverage. But if you have a patient that you don't really think is high risk, you might be able to get away with not having that. Still run like a mercenaire swab and then see if it comes back positive. But not everybody needs vancomycin all the time. If you have somebody with kidney injury, things like that, you might want to avoid that. Our other guidelines, SMFM came out with a statement called maternal sepsis. Again, this maybe doesn't apply to our gynecologic patients as much as the surviving sepsis guidelines do, but I thought it was still reasonable to talk about this. Again, they mentioned that many physiologic changes in pregnancy are going to overlap with sepsis criteria, right? We have patients who are tachycardic, they have high white count, so they're already going to meet some of those. So you got to be, you know, cognizant of that. There's no validated screening tool for sepsis in pregnancy. They just recommend that every institution comes up with their own. We have one at Merida, right? We have a Muse score, and we get called in the middle of the night. You got to go see the patient. You should get some blood work, get a CBC, blood cultures, a UA, a lactate. UA might be going away, by the way, unless you suspect that there's a urinary source. But they're starting to move away from that with some of the new IDSA stuff. CMP, coagulation studies, and I like an ABG. And then you want to get fluid resuscitation like we talked about. Surviving sepsis says the same thing. SMFM says 1 to 2 liters of fluid, which most of our young, healthy patients can tolerate 1 liter. Again, you could always give 500. You can always give more, as I talked about. They also do mention that 30 mLs per kg, but really it's a matter. Well, I was talking about the SMFM guidelines for maternal sepsis. Again, norepinephrine is the first-line vasopressor, antibiotics is 1 hour. Antibiotics. They give us a nice little table of what antibiotics you can use for different conditions. I'm going to go a little bit of an aside here. I'm going to try to do it quick because we're running out of time here. But one thing I want to just harp on, and I think I harp on this a lot, is endometritis, okay, especially postpartum endometritis. There's been a lot of talk about sort of AMP and Gent, or particularly gentamicin and clindamycin are old drugs. So we should be using newer drugs to treat this, okay? And, you know, for chorioamnionitis or IAI, we've been using more like cefoxitin or cefzolin or zosyn, and different hospitals have been coming out with their own protocols. And one thing that is troubling about that for me is that it's not covering group A strep, okay? And I think I sent all the residents a podcast about this one. But group A strep is really lethal, okay? And especially in our postpartum population, there's a 20-fold increased risk of having group A strep in our postpartum patients, particularly postpartum. Again, if it's associated with septic shock, it can have as high of a mortality rate as 40 to 60%. And like I said, 92% of cases are going to present in the postpartum period. And it's going to be multiparous patients, most commonly vaginal bursts, so low risk patients, and they're going to show up, okay, with fever and urine tenderness. Amgen and clindamycin are still the standard of care, okay? I know that hospital policies are changing, but this is still the standard of care. It hasn't changed yet. There's studies that are looking at this. Alternatives to ampicillin and gentamicin are probably appropriate, okay? Zosyn will cover the same bugs. Cefepime should cover the same bugs, okay? But clindamycin still has a role in group A strep, particularly due to its antitoxin effects. And there's studies out there that show that even clindamycin-resistant strains of group A strep can actually still benefit from clindamycin and the antitoxin effect, okay? So even if it's not even treating the bacteria, it can still help with the shock, okay? So my recommendation, that's why there's an asterisk in there, because it's mine, this is not a me thing, is that if I have a patient who shows up in septic shock, particularly in the postpartum period, I'm gonna keep on using clindamycin, and I'll fight with my pharmacist about that, okay? I wanna be a good steward, but I also know that if somebody has group-based strep, it can be really serious, particularly in that postpartum period, okay? Let's get back to Becky. We gotta keep moving on. All right, she gets another 1.5 liters of lactated ringers. Her MAPs hover around 60. So start around some norepinephrine, get some blood cultures. She gets Amgen and Clinda. She's transferred to the ICU, but she does really well. She starts to improve. She gets to the floor the next day. Well, the next day the interns called her room, right? Because now she's short of breath. She's tachycardic. It's really going rough for Becky here, okay? So on exam, she's in mild distress. She has increased work of breathing. Her extremities are cold. She's also reporting some right calf pain. Her vitals, 96/60, respiratory rate 116, respiratory rate 26, sorry, heart rate is 116. And her SpO2 is 86. So this astute intern was like, I'm gonna start some nasal cannula, gets the SpO2 back up, orders some labs and a CTA. I think we all kind of know where we're going here, right? Some form of obstructive or cardiogenic shock, okay? And distinguishing between these sort of causes of shock are difficult. And I'm not expecting really any of y'all to be an expert in diagnosing cardiogenic shock, okay? But what's happening here is getting back to our equations, you know, we're having either a drop in our cardiac output because something's preventing the pump from getting that blood out, right? There's an obstruction. So you got a pulmonary embolism, you have an aortic dissection, right? And the lumen's gone down to nothing, okay? Or maybe there's an outside force compressing the myocardium, like tamponade, or they dropped the lung and now they got pneumothorax, right? And they have tension physiology. Or maybe they have just a dysfunctional myocardium because they had an ACS, right? They had a heart attack, they had a plaque that ruptured off. Now they're clotting off one of their coronary arteries, okay? But when we look at that framework, right, of pump, pipes, volume, in this scenario, it's the pump. We're not able to get that blood around because there's something going wrong with the heart, okay? There's a lot of different ways you can treat this, you know, vasopressors, fluids, inotropes, and you may need all three depending on what the source is, okay? And treatment is gonna be source control, but it's really gonna depend on what the cause is, okay? If you have an obstruction, we gotta remove it, okay? If you've got tension physiology, they need a chest tube. If they've got a heart attack, they're gonna need PCI, okay? Or maybe they need something beyond that. They need ECMO, they need an Impella, they need an enteral aortic balloon pump. We're not gonna do that. Okay. But what you can do is you can go see your patient, okay? Do they have chest pain? What does their symptoms look like? Do they have leg swelling? Is their O2 sats low? What is their history? What do their labs look like, right? Do they have an elevated white count, or is it normal? They have an elevated lactate. Is their BNP up? Is their ABG abnormal? Do some imaging, right? What does their chest X-ray look like? You do POCUS maybe if you're good at that, or you get a CT, get an echo, you get an EKG. You check if they're fluid responsive, right? So we look at that hemodynamic, you know, or those dynamic measurements, right? Can you do a straight leg raise and see if they respond? Can you check their capillary refill? Does the story make sense, right? Because if you have somebody, what you're trying to do is you're trying to rule out your more common things, right? So if they have septic shock, you look at them, you go, does this person look like they have septic shock? Do they look like they have hemorrhagic shock? And if not, then it's time to escalate the care to try and figure out what else is happening, okay? And that's the best thing we can do when we get somebody that's got one of these more uncommon shock states, is to go see them, do the workup, and then escalate the care, okay? And that's how we're gonna manage most of our really atypical shocks. We're gonna be really good at managing hemorrhagic shock. We're gonna be pretty good at managing septic shock when we're done with, you know, training. And then what we really need to be good at is looking out for these other types of shock, just so we don't miss them, okay? I did want to teach something though about obstructive shock because pulmonary embolism was the third most common cause of maternal mortality. So when you have somebody that you think has a pulmonary embolism, there's this thing called a PERC score or a PERC rule, and none of our patients are going to be negative. So it's really irrelevant for us. But if you had somebody who came into the ER, they had a fully negative PERC score, then you could actually send them home. Although there was one case just recently where there was a judgment passed on someone who had a completely negative PERC score, and the doctor still lost. But for the most part, you should be able to exclude a PE, okay? But since all of our patients are not going to fall into that, and I'll show you why in a second here, then you have to go to another system to see, do you need to get imaging to look out for a pulmonary embolism, okay? Here's the PERC score right here, way over here on the, I guess this is your left. And you can see estrogen uses down there. So that rules out, I would call that pregnancy. That would rule out any of our pregnant patients. For our gynecologic patients, most of them are gonna have surgery. So that kind of throws that right out there. And if they're getting surgery for a gynecologic reason, many times they're gonna be over the age of 49. So you're really never gonna have a negative score, okay? So since you don't have your negative PERC score, you either go to like a Wells criteria or modified or a years criteria, okay? And this is really blurry, you can't see this, so I apologize. But there is, in pregnancy, since I am more of a obstetrician, I'm just gonna use this and we're running out of time. But a modified years criteria is something that they actually looked at and validated in pregnancy as a tool that you can use to see if you need to get imaging, okay? And basically what it is, do they have clinical signs of a DVT? If they do, scan their legs, okay? Do they have hemoptysis? And then do you think pulmonary embolism is the #1 cause, okay? So if you have any one of those three, that's a positive years criteria, okay? And then what you do is you get a D-dimer. It says that on here, you can't read it. But you get a D-dimer, if it's greater than 1,000, then you're gonna order a CT scan. Okay, if it's less than 1,000, then you can say it's unlikely to be a pulmonary emboli. But if you have any of those that are positive, like swelling, you're concerned that it's a pulmonary embolism or hemoptysis, then you get a D-dimer, and if it's greater than 500, then you get a CT scan, okay? Treatment for a DVT, you know, that's what happens is if you get the CTA, someone has a positive DVT, okay, there's usually a PERC team, and basically it's a pulmonary embolism response team. It usually involves a cardiologist, a critical care doctor, and whoever else is, you know, maybe an interventional cardiologist, and they're gonna look at all the case and they're gonna decide, does this person need thrombolytics? Do they need mechanical thrombectomy, or do they just need anticoagulation, okay? And each hospital should have their own PERC team, and that's who you should be calling and then making the decisions, okay? And they'll help guide the decision making, all right? Even in the ICU, I still activate the PERC team. And so that's what you should do in that scenario. So if you get called to Becky's room, you go through this sort of algorithm, you figure out, do I need to order the CTA? And then if they have a PE, then you're gonna activate your PERC team, okay? So her D-dimer was elevated at 2,300, CTA was positive for a right submassive pulmonary emboli. She got Lovenox, and then was sent home, and guess what? Wants another baby. I'm almost done. So there's other forms of shock, okay? And I didn't have all the time in the world, and because I could keep going. But other forms of shock will show up in our practice, and it's something to think about, okay? So neurogenic shock can show up as a high spinal or a high epidural, okay? What you're getting is you're getting that sympathetic blockade leading to vasodilation, right? So there's a problem with the pipes. Bradycardia, so there's a problem with the pump, okay? So to fix that, well, we're gonna give some IV fluid. Maybe we're gonna give them a little vasopressor, right? We come in there with phenylephrine and we give them a little push and it jumps back up, right? And that usually will wear off over time. That's neurogenic shock, okay? Otherwise, it's usually trauma. Anaphylactic shock, that can happen, right? Getting this acute hypersensitivity reaction, vasodilation, problem with the pipes. So you're gonna give some vasopressors, some epinephrine to help bring it up. You also give antihistamines. Steroids are not actually recommended. I know we give it a lot of times, but they're actually not recommended. And then you can have a mixed shock picture, right? Like an AFE or amniotic fluid embolism, which is all the shocks all in one. Circulatory failure, okay? Coagulopathy, so the pump's not working, the pipes aren't working because they're dilated because of the systemic response or the cytokine release from the amniotic fluid, and your blood's starting to break down in DIC. This is the worst, okay? So what you're gonna do in this situation, you're gonna do ACLS, okay? Airway, breathing, circulation, all the things. It's the worst, okay? So getting back to this, I guess what I'm hoping you all get out of this is when you go, you call to that patient's room, think about what's happening, right? Think about, is it something wrong where the heart is not working appropriately? It's not getting the blood around? Is it the pipes? They're not able to keep up the resistance that's needed to help keep the blood flow going? Or do they just need more blood because they lost too much? And that's the framework I sort of use when I go see a patient. I'm like thinking to myself, I'm like, what's going on here? Okay. I just wanted to give a couple things too. One of the things, a couple takeaways I got from fellowship is that there's nothing more important, honestly, in my opinion, than going to go see your patient, okay? I know we get these Muse scores, and I know it's in the middle of the night, I know it's late, and you're like, man, I gotta go see this patient. They look fine. But I really want to encourage everybody just to go see the patient, okay? There's a lot of admissions that I was like, this patient doesn't need to come to the ICU. And then there was a lot of times where I'm like, man, I'm really glad they called me because this patient's circling the drain really fast, okay? And I can't get that same, I can't get that same minutia detail and without going to go see the patient. So I really want to encourage everybody, go see your patient, go to the bedside. Anytime a resident will say, oh, we got a consult, I'm like, did you see him yet? I'm like, let's go see him. Let's go see what they look like. Get vascular access. And I want to encourage everybody, when you walk into a room, look at what do they got? What do they got in their arms, okay? Look around, ask. I always do. The minute I go see a consult, I'm like, what do we got for access, okay? And if I need more, I'm going to get more. Or I'm going to ask for more. Sometimes it's hard to get more. I'd say resuscitate early. You can always, like I said, most patients can tolerate that 500 ml bolus. And if they need blood, I'd encourage you to give it earlier than later, especially in our postpartum hemorrhages. And then call for help. I can't emphasize this enough. In fellowship, I was always calling for help because it's nice to have extra people. Sometimes you get confused. There's a lot going on. And when you're in an emergency, it's nice to have an extra set of hands. It's nice to have another person to bounce things off of, ideas off of. And so call for help. And I guess those are my kind of takeaways from this and what I got out of fellowship. I've got a million references that you can look at if you'd like. I'm going to say one more thing and then I'm going to be done. I'll answer any questions. But I want to say thanks to Dr. Hardenbach, who I know is not here, for allowing me to go do this fellowship. I want to say thanks to Mike Beninati because he helped me get the spot and he's been a real great mentor through this. And then Dr. Domeyer for putting up with me and the rest of the ASOG department for taking my call and all that stuff. And then everybody in this department's been really a rewarding experience. I'm glad. I'm happy to come back though to be back here and work with everybody again. So thanks a bunch. Do you have time for questions? Does anybody have any?
Ryan, it's Jay. Are you going to take questions for a second?
Yeah.
I don't really have a question, but I want to make a point about infection. I fall into the bandwagon of the clindamycin too, and I think a lot of people know why. And I've argued with our pharmacists as well as our ID physicians about that. I was wondering if you wanted to touch just for can you hear me?
Yep.
Yeah, I was wondering if you wanted to touch for just a second on Clostridium sordelli, or I can do that real fast. I had a patient that we lost from that infection, and the medical literature, there's from what I can understand, every time I look, there's very rare few cases. There's only been 8 in the United States, and I wondered if you just wanted to touch on it real fast. Or I
mean the Clostridial species, like these are rare bacteria, and there's a bunch of different types, but basically what they do is they're these gas forming bacteria that will ravage through a person. You know, they will, I mean, the one maternal death that I've been associated with was due to a Clostridial species as well. And it's bad. And again, the antitoxin effect from clindamycin, the only other drug that's close is linezolid, okay? And really what it does is it helps sort of like, it helps sort of deactivate that toxin that comes with that, for lack of a better term. And these are the kinds of species that we find in these postpartum infections when these patients die, is when they go back and they look and they do these cultures. It's these Clostridial species that are there. And again, they just rapid moving, you know, soft tissue infections that will cause gas. And that's kind of one of the things that you're looking for, is if there is gas somewhere, so air, you get your CT scan, you've got air in your uterus, or you've got, you know, air going up your groin or something like that, that is bad. And that requires immediate surgical intervention and immediate, you know, antibiotic starting, you know, or initiation. It's that, yeah, and we see that, you know, we'll see that foreign ears getting green, and, you know, in the ICU, we'll get these necrotizing soft tissue infections. And it's really important that you treat that patient surgically as quickly as possible, and then get them in the ICU as fast as possible.
Yep. And for the interns, yeah, for the interns, what I really would add with that one with Clostridium sordelli is typically people will not have a fever, and they'll have an extremely high white count, which can increase, you know, to about 200,000 at times. Once it gets into the uterus, you know, it nears 100% mortality. You have to be really cautious of it and really have your eye out for it. Sometimes you can see it happen after medically induced abortions. There's some thought that misoprostol can change the vaginal pH and allow for it to ascend. It can be a normal bacteria in the genital tract of women. And I will forever be traumatized by it. So just keep an eye out for it, and remember your clindamycin.
I'd just like to make a quick comment if you had time. Our antibiotics actually are selected not just with pharmacy, but with UW infectious disease. And also, I think it's the issue of we need to recognize people that are slipping fast. One of the things we've done a lot of work with sepsis, 60% of our maternal deaths in Merida have been sepsis related. And so we've done a lot of works on a system basis and hospital-based, a wide basis. There is a sepsis oversight committee team here. I'm leaving Merida, so anybody is welcome to join that with internal medicine and ER doctors and things like that. But we have to try to prevent people from getting a sepsis and septic shock. And we have to emphasize the last time we had a meeting is our patients need to be treated like every other patient of sepsis. And also, I think we're just not doing the right amount of training that we should. We're not our residents should have some type of critical care training. We used to have internal medicine training when I was a resident. Actually, we had 6 months of it. POCUS ultrasound is very valuable. We just POCUS somebody who came over last night. They had clear-cut pulmonary edema. Ultrasound is quick, it's cheaper. And so one of the things that you want to do with the patient we saw last night is to see, is their heart working or is their heart not working, to shift cardiogenic or non-cardiogenic pulmonary edema. And so that a patient with sepsis can have both. And so I think that we need to figure out a way to train residents, not just train residents. We have to get attendings and everybody on a different thing. This thing is not going to go away. We just got to figure out how to adjust our training to the needs of our patients.
All right, thanks.
Thank you.